Welcome to Broad Eye, the podcast that explores knowledge gaps in ophthalmology and eye care. Hello, everyone, and welcome to another episode of the Broad Eye podcast. My name is Sean Maloney, and I'm here today with our guest of the day is Dr. Hady Saheb. Dr. Saheb is an assistant professor of ophthalmology and the current director of Glaucoma Fellowship Program at McGill University in Montreal. Hady, welcome to the show.
Thank you, Sean, and thanks for taking on this great initiative to educate colleagues and friends about ophthalmology. It's fantastic.
Great. Well, it's going to be you educating them today. I'm just going to be guiding some of the questions. But just before we were recording, we were just talking about how we've had different touch points throughout our career with a lot of mutual colleagues, and of course, none of those points that I ever have the opportunity to put you in the hot seat and just ask you questions for half an hour. So that's what I'm going to do now. So it should be a lot of fun. So, glaucoma is certainly your wheelhouse, and I thought we could do a bit of a deep dive into glaucoma. And maybe we could just start off with, what is glaucoma and how would you describe that? If you have a patient sitting in your clinic, how would you describe to that individual what glaucoma is?
Yeah, so I usually start by explaining in very broad terms that glaucoma is a pressure-related disease that tends to lead to damage to the optic nerve, and that damage to the optic nerve can cause peripheral and even central vision loss sometimes. And the other important aspect that I like to clarify to patients is that the vision loss is unfortunately irreversible. So that's really prevention and early detection are so key, because if we wait for vision loss to occur, for the patients to notice that their vision has been affected, it's often at a very advanced stage. And so that's really the goal of early detection and prevention. And in my initial description, when I said pressure-related damage to the optic nerve, I deliberately say pressure-related and not high pressure. And so although that's a nuance, I think it's an important one, because some of our patients don't have high pressure, what we call low pressure glaucoma or normal pressure glaucoma. And so that concept of pressure-related damage as opposed to a disease of high pressure is important, because patients need to understand that it's not only about bringing the pressure down, but it's also about making sure that the health of their optic nerve remains stable, whether or not their pressure is statistically normal. And so that's where, a lot of the rest of the education comes in about, how do we follow glaucoma beyond measuring pressure? So we're definitely looking at other tests, which we'll get the chance to talk about, I'm sure, in the next little while, looking at things like visual fields and scans of the optic nerve and examining the optic nerve. So really, in summary, a pressure-related damage to the optic nerve that ends up gradually leading to irreversible peripheral and sometimes central vision loss.
Okay, so there's, I have a lot of follow-on questions there, right? So back in the days when I was first learning a little bit about glaucoma, that was called the dogma. Is like, okay, this is, people get high pressure, so they go to their eye care provider and they measure the pressure in the eye, and it was very common. But has that understanding evolved over time? Because you're alluding to, it's not always a significantly elevated intraocular pressure associated with glaucoma. It's, in some cases, you're saying it is, pressure related, but not necessarily high pressure. So I don't know if you could maybe elaborate on that a little bit.
Yeah, of course. I think, most people out in the community will, meaning on the community, like non-eye care professionals, kind of directly link glaucoma to pressure. That's kind of the first thing that comes to mind when they think of glaucoma. And unfortunately, it is a little bit of a misconception and a little bit of a worrisome misconception, because if pressure is normal, then perhaps that person will say, well, I don't have glaucoma, which is not the case. Thankfully, within the eye care community, I think we're all, much more alert now than decades ago that you can have glaucoma even though you have normal pressure. And so you have to go beyond just the pressure measurement to screen for glaucoma. And I think all our eye care professional colleagues are aligned with that concept. So, you have to look at the optic nerve, and if the optic nerve looks really healthy and the pressure is normal, then likely that patient doesn't have glaucoma. But if the optic nerve looks suspicious for glaucoma, there are specific signs for glaucoma, like a high cup to disc ratio, or certain areas of thinning of the optic nerve rim tissue, or spots of blood called a disc hemorrhage. There are various signs or clues that a patient might have early glaucoma. And so if you have any of those findings, even if your pressure is normal, you should be evaluated more formally for glaucoma. So absolutely that concept, or that direct link between pressure and glaucoma has evolved to include findings of glaucoma with or without high pressure.
So, okay, you're mentioning that it is irreversible. The damage caused by glaucoma is always irreversible. The vision loss. So, if someone doesn't have high pressure, but they do have some of these other optic nerve signs, is there any symptoms at that stage that the person would be experiencing, or is that really just whether or not they're lucky enough to have to see an eye care provider and catch it early on?
Absolutely. Such a great point, Sean, and I'm glad we're touching on this. And we should probably touch on it again as many times as we can in the next little while. The overwhelming majority of glaucoma patients do not have symptoms. And even in patients that have high pressure, they often don't have symptoms. And so the reason for that is because the pressure tends to gradually go up. The eye doesn't tend to feel that pressure when it gradually goes up over weeks or months or years. And so patients can have, normal pressure is 10 to 20. Patients can have pressure of 30, 40, we've even seen 50 sometimes, with zero symptoms. They don't feel anything at all. And so that's really the scary thing about glaucoma, is you can be completely asymptomatic. So we hear patients complaining of a pressure-related sensation all the time. But most of the time, that pressure-related sensation is not actually caused by pressure in the eye, and those patients can have totally normal pressures. The most common cause of pressure-related sensation in the eye is usually some variation of dry eye, where the patients are feeling like an ache in their eye because their eyes are dry or irritated, but not because there's actual pressure in the eye. And then we have patients with pressure in the 40s or 50s that have zero symptoms and have no awareness of the high pressure in their eye. So that's a really important point, because if you're waiting to feel pressure in the eye, of course, that's not at all an accurate or reliable way to screen for glaucoma. So what you said is correct. The way to detect glaucoma is to go and get an eye exam. And so, depending on where you are, that could be with an optometrist or an ophthalmologist for you to get a screening eye exam. And really everybody should have a screening eye exam every 1 to 2 years, but specifically people that have risk factors. And so risk factors for glaucoma are age. So definitely anybody over the age of 50, anybody with a family history of glaucoma. So you should go even younger than 50 if you have a family history of glaucoma, and certain ethnic groups, people of African descent, Hispanic descent, Asian descent. These are all patients that are, or ethnic groups that are more at risk for glaucoma, and should also be screened a little bit earlier in their lives. So yeah, the trick is really to get your eyes examined, because you definitely should not be waiting for symptoms, because that's not a reliable way to screen for glaucoma.
No, and so you're mentioning, there's some, higher prevalence in different ethnic groups. Is there, to your knowledge, is there information out there in terms of, genetic markers of the disease, like certain, genetic underpinnings? Has that been elucidated at this point, or is it just, or very multifactorial?
The simple answer is it's multifactorial. But to go back to your initial question, are there genes that have been associated with glaucoma? Absolutely. There have been some great genetic researchers throughout the international glaucoma community that have identified genes that are more linked to the diagnosis of specific kinds of glaucomas. But these findings have not have not been incorporated into our routine clinical practice, because some people, there are glaucoma variants that have no genetic, no genes associated with them that have been identified yet. And so although it's of interest for research purposes and for general learning, today in today's clinical environment, they're not a reliable or complete way to screen for glaucoma. And so despite all these new findings about genetic links to glaucoma, really the only way to continue to screen for glaucoma in a reliable way is to get an eye exam. Because the reality is, if you had a gene that put you at risk of glaucoma, but your eye exam was perfectly normal, healthy optic nerve, healthy visual fields, healthy scan of the optic nerve, normal pressure, I still wouldn't treat you, right? And if you had no genetic predisposition for glaucoma, but your eye exam showed abnormal pressure, abnormal optic nerve, well, that's a diagnosis of glaucoma and you need to be treated. So although the genetic links are interesting and useful and will likely be part of the future of glaucoma diagnosis and treatment, in today's environment, with what we know about that, the diagnosis and the treatment of glaucoma is still based on that eye exam.
So I've heard, in different conditions in the eye and outside the eye, the expression that, your genes load the gun, but the environment pulls the trigger. Mm-hmm. Is there any environmental factors or modifiable risk factors? And if someone has a strong family history and they say, okay, hey, I want to do everything I can to prevent glaucoma from happening, and I get my annual checkup with my optometrist or ophthalmologist, are there any other modifiable risk factors that people can be aware of?
I get this question almost every day from at least one of my patients. And it's a great question because, is there something I could do to make things better or to reduce my risk from a lifestyle or environmental standpoint? The simple answer is no. Because there hasn't really been any high quality proof of changes in your lifestyle that would really change the outcome of your glaucoma. That being said, there are a few nuances to that answer. One, there have been some recent studies showing that regular exercise might reduce the rate of progression or slow down the natural history of the disease in some patients. And, from my standpoint, exercise is just so useful for so many other parts of your life and your health that I am comfortable recommending regular exercise to anybody who asks me about that. But although, other lifestyle habits like smoking or poor eating are terrible for other parts of your health, there's been no high quality proof that it changes your glaucoma outcome for the better or for the worse. So my general answer to that question is I encourage you to stay healthy for all the right reasons and for the rest of your general health. But for glaucoma, other than staying active, there's no real high quality proof that lifestyle changes will make a big difference in your outcome. So what's going to make a big difference in your outcome is doing your screening if you're not yet diagnosed with glaucoma. And if you are diagnosed with glaucoma, to follow recommendations about treatment, to follow recommendations about frequency of follow-up, to go ahead and get the tests done that that they're being recommended for you by your eye care professional. And so those are really the things that are going to change your outcome, is to go ahead and follow the treatment and follow the recommendations rather than specific lifestyle changes.
No, that makes a lot of sense. I think that's the first time I've ever heard somebody, no, I shouldn't say that. You're not going to say go ahead and smoke, right? But definitely not. But it seems like as time goes on, smoking, poor diet, lack of sleep, lack of exercise, more and more evidence comes out for just about any human pathology that there's some sort of link. So it might just be a question of time. But different types of glaucoma. I think I've heard, I don't know enough about glaucoma. I have a very basic understanding, and I'm learning as we're talking here, which is great. But I've heard that there are different versions of glaucoma. I mean, you can have this actually got covered briefly in an ocular emergencies episode we had before, where someone can have a trauma to the eye and that could cause glaucoma. So I was wondering if you could talk maybe a little about the different types, whether that be what you more commonly see, or what a trauma to the eye, or a consequence of surgery or anything like that.
Yeah.
that can cause glaucoma and what the differences might be.
So the simplest way to categorize, or probably the most common way to categorize glaucoma, is really into open angle glaucoma and angle closure glaucoma. So the angle is a part of the eye where the fluid in the eye called the aqueous drains from inside to outside of the eye. And that angle it's called an angle because it's a junction of two structures in the eye, the cornea and the iris. And so if that angle is open, we call that open angle glaucoma. And if that angle is closed or almost closed, we'll label those patients angle closure glaucoma. And that categorization is really important because if your angle is open, then really the priority is to lower the pressure, and there are different ways to lower the pressure. And if the angle is closed, your initial priority is to mechanically or anatomically open up that angle. And there's different ways to do that, either with laser treatments or surgeries. And so that's really the difference in the initial treatment. Eventually, whether you have an open angle or a closed angle glaucoma, some of the treatments overlap, like lowering the pressure with drops, for example, or certain kinds of later stage surgeries. But really what's different is the initial treatment. So that separation, when you're initially getting a diagnosis of glaucoma, often the eye care professional is really focusing on differentiating between open angle glaucoma and angle closure glaucoma. In North America, open angle glaucoma is the more common kind of glaucoma. And in other areas of the world, specifically Asia and in some of our indigenous populations, angle closure is more common. And then the final comment about that is that within angle closure, you can have chronic angle closure glaucoma, which is more common, and you can also have acute angle closure. So some people call that a glaucoma crisis or a glaucoma attack. And actually people hear about that quite a bit, and people are quite scared of that in the community, even though it is relatively rare. So it's important to be aware of it. If you suddenly have red eye or pain, then you definitely want to be seen rather soon. But the actual frequency or prevalence of angle closure glaucoma, acute angle closure, is actually pretty low. So the more common conditions are really chronic open angle glaucoma or chronic angle closure glaucoma. There are a number of other kinds. Trauma can cause it, a complex surgery can cause it. There are other glaucomas called pigmentary glaucoma or inflammatory glaucoma or pseudoexploitive glaucoma. But these are all more rare than your run-of-the-mill open angle or angle closure glaucoma.
No, it makes sense. No, you were just saying that there's certain populations that are more at risk for chronic angle closure glaucoma versus open angle. Is there, do you think it just has, I guess, why do you think that is? Like, is it genetic? Do you think it's lifestyle? Do you think it's both, or is it just really not well determined?
Yeah, there's for sure a genetic predisposition to having smaller eyes. So in very simple terms, open angle glaucoma tend to have normal or longer eyes, and angle closure glaucoma are more likely to have smaller eyes. That sort of makes sense if you think about what angle closure means, which is that the angle is more narrow or more closed. So if an eye is smaller or shorter, then everything in the eye is going to be a little bit more crowded, and you're going to be more likely to have angle closure glaucoma. So in these populations, so the indigenous and Asian populations, we have found that the front of the eye is more crowded, which is the reason for the risk of angle closure glaucoma. So yes, absolutely, there's a genetic predisposition for that.
Is there more, hyperopia in those populations too, or
exactly right on, Sean? Exactly. So, as you're alluding to, myopia tend to have longer eyes, and then hyperopia tend to have shorter eyes. And so that link between shorter eyes and hyperopia and angle closure, it's all part of the same thought process of an eye being smaller or more crowded.
No, that makes sense. So, okay, I'd just like to talk a little bit about the evolution of treating glaucoma, and maybe you can break it down into subtypes, or you can talk more at later stages if it's a common treatment approach. I think traditionally, I've always thought of treating glaucoma with drops that lower the pressure, but I don't know, I guess how that treatment has evolved over time, or if it has, and then maybe anything that that's coming down the pipeline, or what people are working on.
Yeah, there's been a lot of change in glaucoma diagnostics, glaucoma treatments, and it's part of what makes glaucoma care so exciting, is because we continue to have newer treatments to offer our patients. And so, I've been in practice for almost 10 years now, and the way I treat glaucoma today is significantly different than it was when I started practice, and even more different than when I was training. And so, if I were to try to simplify what the broad strokes are of the evolution of glaucoma care, glaucoma care is becoming a little bit more, not a little bit, a lot more interventional. So what does that mean? In the past, glaucoma care was very much focused on giving drops. So, we prescribe a drop for a patient that they have to take once or twice or 3 times a day, and that kind of becomes their commitment for the rest of their life. And these drops were great. We still use it quite routinely in what we do. However, some of the challenges with taking drops, one is patients remembering to take drops. So terms like compliance and adherence, are they taking their drops every day? Are they refilling their prescription? And we know studies have shown over and over again that there are significant challenges in patients' ability to take drops in a reliable way. And then there's also side effects related to drops. The drops are thankfully tolerable in the majority of cases. However, there's a significant proportion of patients that have side effects like redness or irritation or burning or foreign body sensation, and some cosmetic side effects as well. So all this to say, between compliance issues and side effects and also cost, there's really an interest in finding other ways to lower the pressure in our glaucoma patients. So that's where the various interventions come in. So I would say, the one of the simpler interventions that has gained popularity is something called SLT laser, so selective laser trabeculoplasty. So this has been around for a while, well over a decade, but it's really become repopularized just in the last couple of years. There's been a recent, really well-designed study called the LIGHT trial that has really shown how useful SLT is beyond the initial studies that came out over the last 10 years. So this has been really useful in convincing myself and many of our glaucoma colleagues that we should be offering and mentioning laser treatment right off the bat. In the past it was often like an adjunct or an addition to drops. But I think with that recent study, many of us have moved to making sure we offer patients right off the bat the option of laser treatment versus drops. For some patients, they're just hesitant to do any kind of procedure, and I think that's their right. We want patients to be comfortable. But for those patients who are comfortable with the idea of a procedure, I think starting with laser is really interesting because it removes the burden of taking drops every day and the associated issues with taking drops. It removes that burden from them. And offers them the option of having a safely lower pressure without needing to take drops. So that's kind of the most common or the simplest intervention that's continued to evolve in its role in glaucoma treatment. And then there's also a number of procedures that we have now that weren't available 10 years ago or so in the space of microinvasive glaucoma surgery, which I think we'll talk about a little bit later, that allow us to do surgeries on patients a little bit earlier in the disease spectrum, because 10 or 15 years ago, the only surgeries available were really invasive surgeries called trabeculectomy or tube shunt surgery that are great surgeries. We love performing the surgeries on patients who need them, but the risk profile is significant. So we don't want to have to do that on all of our glaucoma patients. And so really they were reserved for patients that had advanced disease or disease that was really getting worse, where the risk of that kind of surgery was justified. But I think now with less invasive surgery options, we can offer surgery a little bit easier in the disease spectrum. So once again, more interventions that can be offered to patients.
You're talking about this, and we'll dive into microinvasive surgery just in a moment. But, as you're talking about, alternatives to drops, it's amazing how many people, are afraid to take drops, to put drops in their eyes. I know people who would, just over time, who would much rather have, a surgery done, or, an intraocular injection of something versus putting drops in their eyes every day. It's almost like an irrational fear, I guess, right? Of putting drops in the eyes, and some people can't do it very well. And I think in both those cases, compliance goes way down. So, you think that, hey, we have this, treatment regimen that's going to help this person and significantly, And then, you see them, whatever it is, 3 months later, 6 months later, and you realize, things have gotten worse, not better. And then you find out that they, that they just haven't stuck to their regimen of drops for maybe one of the two above two reasons. But I've just heard these stories.
Yeah,
I'm not an ophthalmologist, but I hear these anecdotes from friends of mine in the space, right?
yeah, I think that point's really important because there are some patients that at least in my experience, I haven't really noticed fear so much, but there's really a discomfort, an inability to take the drops. They can try all they want, and it's just they're unable to get it to go in their eyes. I'd say most patients that have those issues will often be patients with some kind of arthritis issues or something wrong with their fingers, or they're unable to press on the bottle properly, or also patients with tremors, or some people just have a inability to not reflexively squeeze their eye when anything comes close to their eye. But I would say that outside of that, most patients who do want to take drops are eventually able to learn how to do it and figure it out. But I think one of the benefits of mentioning right off the bat the idea of an intervention as an alternative to drops is at least patients know that that door is open, and so they're able to, in future visits, come back and say, I know that you offered me a couple of options when we first started and I chose drops, but I'm finding it really hard to take the drops, or I'm finding that I'm forgetting, or I don't like the side effects, or having to go to the pharmacy every month and renewing them is a little bit of an issue, or whatever other reason. And when they know that that door is open, they're able, I think it makes them more comfortable engaging in that conversation to look at different options. Whereas if all you tell them is, okay, you got glaucoma, take drops and see you in a couple of months, maybe they'll be a little bit more shy to mention that they're not able to take the drops as much as regularly as they're supposed to, and be a little bit more shy when they don't know there's another option. They might be more shy to express their concerns about that treatment. So I think the idea of options is really empowering to patients, because when they choose the treatment themselves, I think they're more likely to be engaged and committed to that treatment. So I have found a real benefit in offering two options in initial glaucoma treatment, from an alliance with the patient, and that bond between the physician and the patient, and also their engagement in their treatment, because really they're the ones choosing. I'm sincerely giving them two options, and when they ask me which one I prefer, I say, when I give you two options, because I truly think both options are reasonable. And so, sometimes they push me to really give them my preference, and I'll share it in that case. But I think both options are reasonably similar enough that I truly do give those options to the patients and let them choose based on their personal preference.
That makes a lot of sense. Just a question. This is a very basic question that I probably should know the answer to, but is glaucoma typically bilateral?
So most glaucomas are bilateral. So there can certainly be an asymmetry in the glaucoma, and every now and then there is a unilateral glaucoma. But I'd say most routine glaucomas are bilateral.
Okay, no, it just makes sense. I'm just trying to think about
Mhm.
how it might develop and whatnot. Obviously, if it's a trauma, then it might be unilateral. But I don't know if there's any theories on the asymmetry. Like, I mean, that's in other diseases. I have retinitis pigmentosa, as you know,
Mhm.
and there is asymmetric progression of that disease in many patients, where one eye will get worse faster than the other. In glaucoma, I guess it can happen as well. Is there any, to your knowledge, any theories on why that is, or is just kind of the way it is?
Yeah, I think a number of the studies that have looked at unilateral asymmetric glaucoma, their conclusion has been, after looking at a number of things and really looking for more complex explanations for the asymmetry, often the answer has been that there's usually some kind of a secondary glaucoma in that eye. So, a common secondary glaucoma is a condition called pseudo-exfoliation glaucoma. And so often in pseudo-exfoliation glaucoma, there is one eye that is worse than the other. And it's just the nature of that specific disease, where there tends to be that abnormal deposit that accumulates a little bit more in one eye than the other. And so that's a common cause for very asymmetric glaucoma, or even in some cases unilateral glaucoma. And then a number of the other secondary glaucomas, like you mentioned, trauma or inflammation in the eye, or another secondary glaucoma called pigmentary glaucoma. So those are conditions that are more likely to be unilateral or very asymmetric. And so, but routine primary open-angle glaucoma, although it can be asymmetric, it's less predisposed to having these significant asymmetries or the significant or being unilateral. So whenever you have like a unilateral condition, as a clinician, my first reaction is to look for a secondary cause, to look for a reason for that patient to have unilateral glaucoma, because it is quite unusual in people that just have run-of-the-mill glaucoma, which we call primary open-angle glaucoma. And what primary means is there's no identifiable cause. And in those cases of primary open-angle glaucoma, it would be quite surprising to have it be unilateral.
No, that makes sense. I thought we could circle back to microinvasive surgery. So I know that you have research focused around microinvasive surgery. So I thought maybe you could just talk a little bit about that research and just about the space in general. Why is microinvasive surgery, of interest to you and to the field in general?
Yeah, so just a little bit of to press rewind for a little bit, because I think the perspective here is so important. Anybody that researches, MIGS, so microinvasive glaucoma surgery today, will just see a plethora of literature and data and experience of MIGS, and if you're researching today, it just looks like MIGS is part of what we do and is a really important part of glaucoma treatment options. But in 2012, I was one of the authors on a paper that defined MIGS. And at that time, I remember so clearly that all it was really an idea with a few devices in their early phases of usage and research, and remained quite controversial, like any innovation. In the beginning, it's often controversial. And so that's 2012. That's less than 10 years ago. And here we are today with a number of new options, a ton of investment in research studies on these devices, and really glaucoma leaders throughout the world using this and trying to better understand these devices to really figure out which devices work in which patients. So I think we've answered the questions: do these devices work? Yes, they do. And I think we've answered the question: are they safe? Yes, they are. And what remains to be answered is, well, how do they compare to one another? Because we have a number of mixed devices. And how do we really personalize care in choosing which of these devices we put in each of our patients? So to take a step back again and define MIGS, so microinvasive glaucoma surgery, the premise is really that the priority is safety and visual recovery. Amongst MIGS procedures, the priority is to submit the patients at the least amount of risk. And so I was referring earlier to our traditional glaucoma surgeries, which are called trabeculectomy and tube shunt surgeries, that are great surgeries that work in our most advanced of glaucoma patients, because those patients need what we call our big guns. You need an invasive surgery, kind of the equivalent of a cardiac surgery, open heart bypass. Those hearts are so thick, that's the only option. You need to just bypass the vessels in the heart. So similarly, in glaucoma, you need to bypass the drainage system and do a trabeculectomy or tube shunt surgery in our sickest of patients. But the point of microinvasive glaucoma surgery is, in some patients, you don't need to do all of that. And perhaps you can offer them something safer that's not as big of a gun, because that patient doesn't need it. So kind of the equivalent in cardiac care would be the stenting that interventional cardiologists do in patients that don't necessarily need an open heart surgery. So often these sort of stenting procedures or cutting procedures or tissue removal procedures that are less invasive and can offer a pressure reduction without the amount of risk that the more invasive surgeries do. So from a glaucoma practitioner standpoint, what makes this so great is that when a patient comes to see me needing glaucoma surgery, I have anywhere between 5 and 10 options for each of those patients, and depending on their level of disease, how many drops they're on, how high their pressure is, what their lifestyle is like, how old they are, I'm able to look at those options and really customize care for that specific patient. And there's nothing more rewarding to a practitioner to feel like we're moving towards personalized care for glaucoma patients.
So I think that's certainly a good overview on that. And on the rewarding side of things, I'm going to put you on the spot here for just maybe one last question before we wrap up. I think we've done a pretty good job, or you have done a good job of giving an overview of glaucoma, the who, what, where, when, why, how, so to speak. But I'm just curious, why glaucoma? Why did you, of all the different specialties in ophthalmology, or even why ophthalmology for that matter, what led you down that path and doing what you're doing right now?
Yeah, that's not putting me on the spot. This is something I think about all the time. So I'm definitely happy to share. I am so happy I chose glaucoma just to start. I find what I do so rewarding on many levels. And so I'll start with the patient interaction. So glaucoma is a chronic condition. So some of my patients come in for glaucoma surgery and then go back to their regular ophthalmologist or optometrist because they don't necessarily need my care. So those patients I don't necessarily have a chronic relationship with, although I'll see them before surgery, during surgery, and after surgery for usually a couple of months or so. So there is a little bit of relationship there. But for my patients that need to stay under my care long term, I'll see those patients for years, and that relationship and that trust that builds over time is quite rewarding. So that's on the patient interaction standpoint. On a surgical standpoint, it's rewarding because there are a number of surgical options. And so I'm always, performing different procedures, whether there's lasers or surgeries in the operating room. And also the field is quite dynamic in that we are continuing to have more options for patients. So as a surgeon, you're continuing to evolve. What I do with surgeries today are very different than the surgeries I did during training. And likely the surgeries I'm going to do in 10 years from now are going to be different as well. So that the number of options I can offer patients and my evolution as a surgeon is really rewarding. And then you are truly, saving vision. So from an impact standpoint, there are a lot of my patients that you just know that they would have otherwise gone blind, and we're not able to save everybody, but we're able to save the majority of patients' vision. And to know that you're doing that on a daily basis is pretty hard to beat. And then other aspects are, I work at an academic center. We have medical students, residents, and fellows, and to see them evolve in their training and their ability to care for patients, and to know that, we're part of the process of training the next generation of ophthalmologists and glaucoma specialists is great. And it's probably one of my favorite parts of what I do is the teaching aspect as well. So. And then there's the research and the health leadership and the political aspects of everything I do that are rewarding as well. But yeah, so that's a long-winded answer to why I chose glaucoma, and I would absolutely make the same decision again if I were in training today.
No, that's great, and I think that you're the director of the fellowship program, and I think that just participating in the podcast here today is certainly a testament to at least one of those pillars in terms of teaching and education. So I want to take the opportunity to thank you for joining us today. I think that I know I've definitely learned some things. I feel like some of them I should have known from past experience, but I didn't, and certainly some new things as well. So I appreciate you sharing that information with me and with the audience. And it's just a pleasure to have you on the show.
Awesome. Well, thank you, Sean, for thinking me for glaucoma, and for all the work that you're doing in the eye care education space. So keep up the great work, and I hope that was enjoyable to you and all your listeners.
Excellent. Thank you.
Take care.
And that concludes today's episode of the Broad Eye Podcast. If you enjoyed this episode, please be sure to subscribe on your favorite podcast platform. Of course, ratings and reviews are always welcome. And you can certainly share this episode with any of your colleagues or friends who might enjoy it. Thanks for listening.